Good afternoon, one and all. Welcome to yet another enthralling session of FB Live. Neuroscience research is progressing at a rapid rate. Advancements in tool and new techniques are enabling neuroscientists to forge inroads towards an understanding of the brain. To understand the recent advancements in the field of brain and spine surgery, we have with us Dr. S. Sundararajan, Senior Consultant Neurosurgeon, Apollo Specialty Hospitals, Madurai.
Hello.
Good evening, good afternoon, doctor.
Good afternoon.
Doctor, can you tell us what are the conditions that actually needs a brain and a spine surgery?
There are a variety of conditions which need brain and spine surgery. The indications are very exhaustive that you can't cover in a single session. But briefly, in the brain, you can operate on the brain for, say, for example, head injuries, number one. Number two, congenital anomalies, that is birth defects of the brain. Number three, tumors of the brain. Number four, other abnormalities of the brain like vascular abnormalities, where there is a rupture of a blood vessel in the brain. There are a variety of such conditions in the brain which need surgery. That is number one. And in the spine, again, it can be because of a injury to the spine, like for example a spine fracture which will need a fixation, or it can be a degenerative condition like a cervical spondylosis or lumbar spondylosis or disc prolapse. And again, tumors also can occur in the spine, which also will need a surgery. So these are not exhaustive list. There are many other conditions in which brain and spine surgeries are required for a particular patient.
So doctor, coming to head injuries, how does the helmet protect us from head injuries?
It's a simple mechanical factor. Suppose if you bang against a particular wall with your bare fingers or a bare wrist, obviously you will get more injuries. Suppose if you wear a glove, a padded glove, and then do the same thing, your fingers will be protected. Similarly, if you wear a helmet, it's going to protect your head against banging against a hard surface like a stone or a pavement or a post or a pillar or whatever it is. So obviously it absorbs the shock waves that are transmitted into the brain, thus protecting the brain.
Doctor, we know head injuries are quite serious, but how to know if someone is to be shifted to hospital as an emergency?
As soon this public have to be aware of all these things. Like suppose if you see a person on the road who has suffered a head injury, apparently a head injury. So suppose if the patient is quite conscious, is able to talk, is able to move his limbs, then you should presume that no major brain injury has happened, at least immediately. If the patient is unconscious, totally not responding to any of your calls, number one. Number two, he is throwing a seizure or what is called a fits, or if he is bleeding from his ear or nose, or if he is does not move the limbs at all, or if his breathing is not at all normal. So these are the conditions in which you should recognize that there is a major intracranial or brain injury, and so immediately you should make arrangement to shift the patient. So this is also to prioritize. Suppose if there are 4 or 5 patients are involved in the same accident, you should prioritize in this way. So you should give importance to the person who are having those symptoms which I said, rather than the person who is sitting and talking.
So in a head injury scenario, what should an observer do, doctor?
He should immediately concentrate on what is called A, B and C. That is what we shortly call A, B and C. So in short, it's A stands for airway. You should not crowd around the patient. You should make the patient lie on his side so that he is able to breathe properly. If there is anything obstructing his respiration, say for example a blood clot or some dirt or cloth against his nose or airway, then you have to clear it, number one. Number two is breathing or bleeding. So this we have to assess by looking at his breathing pattern. If he is not at all breathing, then we may have to undertake a cardiopulmonary resuscitation, for which every single individual should know about cardiopulmonary resuscitation, how to give mouth-to-mouth breathing, etc. We can also stand for bleeding. Bleeding means with a head injury, bleeding can be very severe. So what one has to do is apply a firm pressure at the site of bleeding. That is the number one therapy you can give to stop the bleeding. Then C is circulation. Circulation is nothing but the blood pressure. If there is too much of blood loss, then the blood pressure will fall. There will be loss of blood volume. But at the site of accident, it is difficult to do anything about it. You can stop the bleeding and ask for an ambulance service, which should start an IV line, intravenous line to supplement the blood loss. These are the basic essentials, and while transporting the patient also, you have to be very careful to see that the patient's tongue does not fall behind, so that you put the patient on the side to see that head is lower than the chest. These are some of the things which will prevent you from further sustaining injuries.
So doctor, what are the long-term outcome of a head injury?
The long-term outcome of a head injury depends much on the initial presentation, like what has happened to the brain at the site of impact or immediately after injury. Suppose broadly you can classify it into a mild head injury, moderate and severe head injuries. So we have a score for this, a rough score for these things to classify these patients. So if there is a mild head injury, usually patients recover very well. So a moderate head injury patients, yes, there are chances, if proper treatment is given, there are chances for him to recover. A severe head injury patients, the outcomes are generally not very good, but much depends on the early treatment for such patients, how early they are transported to a center for excellence in such care, and then how they are treated, and of course the inherent patient factors also determine. Basically, it is the severity of the head injury which decides on the outcome.
Coming to spine, doctor, tell us how to protect us from spine injuries.
It is basic. Most of our spine injuries that we see are from two-wheelers, sustained in two-wheeler accidents. So today's youth, they care a little while driving the two-wheelers. Two-wheelers have to be very, very carefully driven, and you have to adhere to all precautions, the speed, the weaving through the traffic, the speed at which they go, the reckless driving, all these things contribute to spine injuries. So that has to be taken care of. That is number one. The second thing is, second type of spine injuries that we see is from diving injuries, like in a pond or something. In the village side, it's very common to have a dive into the pond. So you have to assess that the depth of the pond is sufficient enough to dive. Otherwise, your head will hit against the floor of the pond, and then you can sustain a head injury. The third thing is, whenever a patient is having a severe head injury, you should always assume that the patient is also having a spine injury. So you have to take care of a patient with severe head injury and assume that he is also having a spine injury. That way, anything which protects you from head injury also will protect you from spine injuries. And seat belt wearing, another thing I forgot, is the compulsory seat belt wearing. Not only the passengers in the front, the passengers in the rear also have to wear seat belts. Otherwise, what is called whiplash injuries are very common nowadays in high speed accidents on the highways.
Doctor, what to do as the first step when our spine get injured?
The number one step to do when the spine obviously has got injured is the transportation method. So one should not lift the patient from the site of accident recklessly. So one has to try to get a hard board. Suppose if it is not possible, at least try to place the patient in a flat plane, and then it's better to keep the patient slightly in a prone position. Prone position means face down position, and see to it that when the patient is transported, the spine is not flexed. That is, somebody holding on the head side, somebody holding on the trunk side, somebody holding on the leg side should be in the same plane. One should not flex the spine. These are some of the important factors while transporting, and all the ambulances should have what is called a spine board. A spine board is a flat wooden board which is essential to shift this patient. This is just to avoid further injury to the already injured spine. So this is the very important thing to be taken care of.
So what are the treatments for a spine injury?
The treatment of spine injury starts, as I said, it is from the site of accident itself it starts. So at the site of accident, the transportation is very important. And when it arrives to a hospital, it is better, suppose if you suspect a severe spine injury, it is better to refer to the patient to a hospital where spine injuries are being done. Because there has to be a comprehensive management. So at the during transport also, the patient has to be carefully transported. Once the patient arrives at the center where it is being treated, patients basically receive basic medications like first painkillers, because pain will be very severe in many of the spine injuries. So they should receive number one is painkillers, and number two is securing the spine, especially the cervical spine. We should always, even ambulances should always have what is called a hard collar, hard cervical collar. They should put the hard cervical collar so that it doesn't move further. So similarly in the hospital also, we secure the cervical spine with a hard collar, and then again all the movement precautions which I said for transporting also holds good while in the hospital. And then the second line of treatment begins with the investigations, an MRI scan, a CT scan of the spine, sometimes X-rays alone will suffice, and then administration of certain drugs like methylprednisolone, which reduces the spinal cord injury. Most important is the assessment of the degree of spinal injury by a neurologist or neurosurgeon, and then subsequently whether to decide whether to patient needs a surgery or not. Once images are out, once MRI images or CT images are out, then we'll decide whether to do a surgery or not. If surgery is decided upon, then we immediately undertake the surgery. Otherwise, patient goes to the ICU for further care.
So coming to tumors, doctor, are all brain tumors life-threatening?
Basically, there are a variety of brain tumors, but basically broadly for general purposes, you can classify the brain tumors into a benign tumor, otherwise a non-cancerous tumor and a cancerous tumor. Unfortunately, the number of tumors belonging to the cancer variety is more than the numbers belonging to the non-cancer variety. But still, if he gets a brain, if he or she gets a brain tumor, it doesn't necessarily mean that he or she has to panic, because there are a variety of treatments available. In general, a benign tumor will have a favorable prognosis, not all times, but a malignant tumor in general will have an unfavorable prognosis. That is in general.
What are the modern methods in brain tumor surgeries?
Like for example, the degree of safety that has come with that has been developed for the treatment of brain tumors have enormously developed in the recent years. The first and foremost is the advent of microsurgery, which of course dates back to several decades, but modern microscopes have made the brain tumor surgeries very, very safe. And even before the surgeries, the diagnosis of brain tumors have been revolutionized by a variety of imaging techniques. For example, MRIs. MRIs have got varieties of modalities to know the nature of the brain tumor, the location of the brain tumor, the vascularity, that is a blood supply to the brain tumor. Not only that, we can also have certain advanced techniques in the CT scan and MRI scan where we localize the site of the brain tumor, like with the relationship to functional areas. For example, if it is very close to the speech area, if it is close to the area which controls the leg or arms, all these things can be very, very easily discerned by preoperative investigations. Then during surgery, again we have a variety of tools, like for example, say with the advanced microscope, we have some neuronavigations. Neuronavigation is nothing but trying to use your Google map to find out a place where you want to go. Similarly, we have a navigation to the brain also, where precisely we can localize the brain tumor so that we can avoid important areas of the brain which are functional. The third is that with the use of the microscope, we have certain advanced techniques like fluorescence, wherein in case of say a cancer tumor, we put some dye into the patient so that the area of the brain which contains the tumor, they have a fluorescence. They get illuminated by use of some filters in the microscope, so that those abnormal areas can be effectively targeted. And then we have other variety of techniques like intraoperative imaging, which can tell you how far we have removed the tumor. These are some of the important, and we have other techniques of removing the tumor. Say for example a QSAP, that is nothing but an ultrasonic suction aspirator, which helps in good tumor clearance. So with all these techniques that we use, current brain tumor surgery, unlike a few decades ago, have become very, very safe. The mortality rate has dropped dramatically.
There is a myth circulating that the patient die after brain surgery. Is there any truth behind that, doctor?
The patients die because of the disease of the brain. They seldom die due to brain surgery because, as I said, yes, that does carry a lot of risks, understandably, but as I said, the mortality rate has come down drastically. So one need not fear the surgery just because the patient will die. Patients die because of the illness, the disease, not because of the surgery.
People say you will be paralyzed if you operate on spine. What about this, doctor? Any truth in it?
Yes. You cannot say that it is absolutely false, but the thing is, as I again said, the degree of safety that you take, the degree of technology that you use, the degree of expertise that you have, and the modern methods, all these things go to safeguard your chances of getting paralyzed after a spine surgery. Before you embark on the surgery, suppose the patient had already been paralyzed, say for example due to an advanced spinal tumor or a severe injury to the spinal cord, then there is not much that you can do. But say for example after safe removal of a tumors, patients have from zero power, they have walked back home. These things will happen. So what we call the risk of getting paralyzed is a complication inherent with the spine surgery, but with the careful precautions and very dedicated surgical techniques, the incidence is very, very low.
A query from one of our patients. I had a brain tumor surgery in August 2016. How do I motivate myself to live happily? As per my research, I found that the survival rate after surgery is far very less years.
Yes, there is a certain amount of limits to the degree of treatment that we can offer at present for advanced brain cancers. There are a variety of, the survival rates have increased dramatically. For example, there is a particular very aggressive brain tumor called the glioblastoma multiforme. In the previous years, once a patient is diagnosed of glioblastoma multiforme, if they used to say, even in textbooks used to say that if the patient lives beyond 1 year after this particular diagnosis with all the modalities of treatment, then probably the diagnosis is wrong. To such an extent it was a killer. But later with the advancement in techniques, the longevity has increased. So one has to rehabilitate himself, one has to motivate himself to carry on his profession, and the rest will be decided by the biology of the tumor.
So doctor, what is the usual recovery period after a brain tumor surgery?
Most of our brain tumors nowadays, depending on the pre-operative condition of the patient, especially brain tumors and even malignant tumors also. Say for example, if we do the surgery right about now, say about 3 o'clock in the evening, and carry on till about 6 o'clock, 7 o'clock. By night 11 o'clock we allow the patient to take fluids and if possible solids also. The next day in all possibility the patient will be having his or her breakfast. Such is the thing nowadays. Yes, some of the conditions will require a prolonged ICU care, some ventilatory care. All these things depends on the location of the tumor, the size of the tumor, the aggressiveness of the tumor, and how was the pre-operative condition of the patient. All these things will decide on how the patient will behave after brain tumor surgery.
So what are the common after effects of a brain surgery?
The after effects again depends on the location of the brain tumor. Say for example, if the patient's brain tumor is bang on the area, what we call eloquent area. Eloquent area is nothing but an area of the brain which controls vital functions. Say for example vision, say for example speech, movement of the limbs, all the and the eyesight. Some of the areas which control these vital functions, if they are involved in the tumor, of course we will take care to see that these areas are not further damaged. Whatever already has been damaged by the tumor is there, but we will take care to see that further damage is not caused. But these things, if they get affected, yes, patients do have some post-operative deficits. Our aim is to minimize such deficits.
So how fast can a brain tumor grow back?
It is decided by the pathology of the brain tumor. The pathology means the nature of the brain tumor. Some of these tumors like the glioblastoma multiforme, they recur very fast. Within weeks they can grow back. But benign tumors generally they do not grow back at all. Some of the benign tumors also grow over a period of weeks to years sometimes. Low grade tumors, even cancer tumors, low grade tumors can have years of progression free survival. Eventually after years they may regrow again. So more malignant the tumor, earlier the growth. More less malignant the tumor, later the growth. Benign tumors, most of them do not regrow, but still they can also regrow at a very much slower rate than that of a malignant tumor. So it is decided by the biology of the tumor.
Are brain tumors always cancerous?
No, as I already said, unfortunately the majority of the brain tumors, the percentage wise, the most of the brain tumors are cancerous, but there are also gradation in the cancer severity. Like for example, an astrocytoma is a type of a brain tumor wherein you have a grade 1, grade 2, grade 3, grade 4. A grade 1 tumor is almost like a benign tumor. Grade 1, grade 2 behave very well, whereas grade 3, grade 4 tumors behave very aggressively. So it depends on the grade of the tumor that decides on the aggressivity of the tumor.
Doctor, how many surgeries have you performed on people with this tumor type or location?
I've been operating on the brain tumors for the past nearly a quarter of a century. So should be, I don't have an exact number, should be anywhere between around 2,500 tumors.
Will the patient be awake during the surgery?
Yes, there is a particular type of a technique. As I said, we have certain safeguards. I already mentioned in the earlier part of the speech that there are certain precautions that we take while operating on the brain tumors to safeguard the areas of interest, eloquent areas of the brain. So one such method is what is called an awake craniotomy. An awake craniotomy is nothing but a patient during dissection of vital areas of the brain, the patient is awake. How is it possible? Like the anesthetist is important in such a situation. The anesthetist keeps the patient awake by careful titration of the drugs. So what we do is, while dissecting on those particular areas, for example, we are close to the speech area, we'll stimulate the speech area. A dedicated electrophysiologist will be there. So we will be stimulating the speech area with a set of what is called electrodes. So we ask the patient to count. Say, for example, ask the patient to count numbers. If you stimulate that particular area, which we think is the speech area, there will be a speech arrest. So we will know exactly, okay, that area is dangerous, we should know. We will mark that area, we won't go near that area while dissecting the tumor. Handling the brain in those areas will be very, very careful. So this is similarly movement of the limbs. If an area we think is important, which moves the right upper limb, for example. So then that area, if we stimulate, if the patient is not able to move, then we'll know, okay, this area is important. So this is the importance of awake surgery. So in certain selected cases, we can do an awake craniotomy.
So how does the tumor location affect my outcome and your strategy?
Yes. Again, the same concept of eloquence. Tumor location, sometimes certain areas of the brain are called silent areas. For example, the frontal lobes, the basifrontal lobes, what we call, just above your eyes and the nose. So sometimes, especially on the right side, these areas remain silent for a long time. That is one location, and the rate of growth also. If the rate of growth is very slow, and tumor is a slow growing tumor based on this particular location called silent areas, like the area which I mentioned example. So these grow to a large size before it can be detected. So some areas will be very, very sensitive, like for example in the motor area, which means movement of the limbs are affected by this area, or a speech area. If a tumor grows in this particular area, what happens is you will get notice of it, because patient's complaint will be immediate. Similarly, a patient can present with the fits. So if the patient presents with the fits, then it can be easily diagnosed. This is what happens to area of the tumor, how it decides. Again, it will also dictate the strategies which we undertake in dissecting these tumors. Already I discussed about the MRI scans, the functional MRI scans, the awake craniotomies, the fluorescence. All these things we pay more attention if the tumor is in those important areas. That strategies will vary according to the location of the tumor in this particular way.
Doctor, explain us the risks and benefits of the surgery.
The benefits of a brain tumor surgery is very obvious. Whenever there is a tumor, there is no known therapy so far for a known brain tumor, no known drug which will completely dissolve the tumor and make it disappear. So the prime thing is removal of the tumor. Otherwise we call it debulking of the tumor. Removal of the tumor will enable you to further undergo therapy like radiotherapy or chemotherapy. Second thing, important thing is you must understand the difference between a tumor which is present in other areas of the body like abdomen and a tumor which is present inside the skull. Inside the skull there is limited space. It is enclosed in a skull cavity. So when the tumor is growing, there is no space for the tumor. It is only the brain that occupies the entire skull. So when it grows inside, there is increase in intracranial pressure. Like your blood pressure, there is an increase in intracranial pressure, which has to be relieved. This can be effectively relieved by taking out the tumor. That is one more important thing. So removal of the offending agent and reduction of blood pressure, removal of pressure on important areas like say for example, if a tumor is pressing on the optic nerve, patient will lose vision. So by removing the tumor, you make the patient regain the vision. So these are some of the benefits of tumor surgery.
We have a question from a patient from Tripura. I am suffering from arthritis related to spinal cord, which results in lower back pain, especially when I bend or work in sitting position, and back stiffs preventing me from bending. What type of precaution should I follow? Is therapy enough or should I take any medicine?
It's a broad question. The reason for such a thing can be multifactorial. Depending on the age of the patient, it may be just a routine degenerative spondylosis. A degenerative spondylosis is nothing but what you get in say for example a knee joint arthritis, something like that. There is also a lot of joints in the back also. So one joint is the disc space, that is intervertebral disc, the space that is occupied by a jelly-like substance in between two bones, and there are other two joints also and in the vertebra at the back. So every vertebra has got these joints. So if the joint gets inflamed, it becomes degenerate, the disc loses its jelly-like nature, becomes hard and stiff. These things all contribute to pain. This is the commonest condition which will lead on to back pain. The back pain can be relieved by a variety of maneuvers, starting from simple back exercise, strengthening of back muscles, followed by application of topical medications, intake of medications. In severe cases, you can have injections, and you have an excellent set of physiotherapeutic measures which will reduce the pain. But ultimately, just treating the back pain is not enough. Trying to know the reason for the back pain, reason for the stiffness is important before you start on the therapy. That will be enabled by a set of investigations like an X-ray, especially an MRI scan, which should be shown to a proper a spine surgeon like a neurosurgeon, so that he can dictate you once the cause is known, then you can undergo a therapy depending on the requirement of the nature of the disease.
Doctor, will there be any cognitive problems after surgery?
After brain surgery, that is. Yes, cognition can be affected by a variety of tumors. It can be affected by head injuries. If there is, for example, a diffuse brain injury. A diffuse brain injury is nothing but like you drop an electronic item on the floor, where when you look at say for example, you drop a cell phone and you see there is not much of a damage that is visible outside, but you switch on the phone, it doesn't work. So similarly, you can get a head injury wherein you suffer a severe head injury. You take an MRI scan, you take a CT scan, there is not much, very little of injury. But then the patient is unconscious, needs ventilation, does not move his limbs, all these things. So later when the patient recovers, he may have some cognitive disturbances, like for example, loss of memory, loss of ability to recognize people, behavioral disturbances, inability to identify people. All these things can happen. All these behavioral changes are very, very prominent in certain areas of the brain. memory disturbances are prominent when other areas of the brain are affected. So again, each location of the brain, if it suffers an injury, will lead on to specific cognitive disturbances.
Doctor, tell me about the duration of the hospital stay after the surgery.
After a brain tumor surgery. Yeah, after a brain tumor surgery, as I said, we rehabilitate very fast. Some of the cases, in the overnight, the patient recovers very well, and typically in a few days, maybe 2 or 3 days, the patients will have what is called a drain in the skin to avoid some collection under the skin of the scalp. So these things typically take about 2 or 3 days. So otherwise, patients used to go home after about 2 to 3 days if there are no outstanding issues.
Doctor, I have one more query from the patient. Can I have the sample of my tumor tissue frozen so that I can be a candidate for a vaccine in the future and have genetic tests?
Yes, but right now vaccine therapy for brain tumors is at its infancy. It's not widespread. It is being carried out in certain research centers. Some promising results have come, say for example from the University of California. They have what is called a dendritic. There are a variety of vaccines trying to develop, even from viruses like, for example, your common polio virus vaccines. They are trying to modify the polio virus vaccines, trying to do a immunotherapy. These are the immune therapy basically depends on what are called monoclonal antibodies. So all the drugs which are coming out of these things will be ending with the MAB, so monoclonal antibodies. So some of them are developed from even polio virus, some have tried measles virus, and some have even tried the lesser known Zika virus that was an epidemic few years ago. So, and another important thing is from the tissue that you take from your brain tumor. The basic thing is you separate some of the cells from the brain tumor, and then you add it to the what are called dendritic cells from the blood, and then mix it and prepare a customized vaccine for you, for your particular body, and then you inject it. This has given some promising results. As I said, it is in infancy. For example, I said the glioblastoma multiforme is a very, very aggressive brain tumor whose longevity of the patient, even now it's about, say, about 15 months, something like that, 15, 17 months typically. This has shown some promise in that these vaccines have improved the life to up to 23 months or 24 months. So at present, this is that much only can be achieved, could be achieved. So probably in future, this will come in a long way.
So doctor, who and all will be involved with the recovery care and how long?
The recovery care is typically it's all a teamwork, right from the beginning of the patient's reception into the hospital. In the theater, it's a big team, and then in the recovery team also is very big. So basically, it involves a neurosurgeon. In case of brain tumors and head injuries, it's the primary consultant is the neurosurgeon, and then we also involve the neurologists, the intensive care experts, the anesthetists. These are a very important thing. And if the patient has multiple injuries, other specialities also come into action. And then we have very important thing is the neuronursing. Nursing has to be very, very careful because those are the people who stay with the patient for 24 hours. So neuronursing is a separate topic on its own. And then we have the physiotherapists, speech therapists, intensivists, everything. It's a big team that is involved in recovering the patient.
So doctor, what is a spine fixation device?
Yes. See, in case of spine injury, the primary thing is we look into two things. One is the spinal cord which goes inside the spine, which is protected basically by the bony spine. So when it has to be intact, the bony spine has to be intact to protect the spinal cord. Our aim is to protect the spinal cord. So when the bone is broken, sometimes it is broken in a few unimportant places, or it is broken in such a way that it doesn't move abnormally. When there is an abnormal movement of the spine in a major fracture or in an important location in the spine, it is called an unstable spine. An unstable spine has to be fixed. One, to attain stability, to move the patient, to nurse the patient. Another thing is to avoid further injury to the spinal cord. So this is how a fixation of the spine is achieved by using a variety of implants, what we call implants. Basically, The basic implant is a screw. A screw and a rod is a basic implant used in the spine. There are, of course, a variety of implants that are used in the spine. These are spine fixation device broadly.
Doctor, explain us what is spine stabilization surgery.
This part of the answer is in the previous question. Like spine stabilization, as I already explained to you about the instability that the spine faces after a trauma, or even after an extensive surgery in the spine, you can have an instability of the spine. So the spinal fixation devices, they help to stabilize the spine, one, to restore the anatomy to its original position, and then to avoid abnormal movements at the spine while the patient is walking, standing, sitting, traveling, whatever it is. So we fix the spine using these devices. So this is basically the spinal fixation, spine stabilization, otherwise it's called.
So who needs a spinal stabilization surgery?
All patients who suffer a trauma which results in spinal instability will need a spine fixation. That is number one. Number two is sometimes we undertake a surgery for other reasons. Say for example a cervical spondylosis, wherein we have to extensively dissect certain parts of the spine, and then say for example if there is a spinal tumor which is present and we are opening the spine in a long way, in a long segment, several segments of the vertebra are opened, then there will be some instability. So in such cases what we do is we put in screws and then stabilize the spine, so that the injury caused by our surgery will be mitigated by the stabilization.
So how long does it take to recover from spinal stabilization surgery?
Spinal stabilization, if it is done for an injury, we tend to put the patient, depending if the patient has got no deficits, no inability to move, then typically within a week we try to put in a belt or a brace, what we call a brace, and then mobilize the patient as early as possible, because lying in the bed is the thing which is detrimental to patients, especially elderly patients. So we try to move the patient out of the bed. But if the patient is paralyzed, of course, typically it will take several weeks until the patients recover.
Is spinal fusion a major surgery?
Yes, spinal fusion is a major surgery. Again, spinal fusion means that suppose if we stabilize a patient, stabilize the spine with screws and rods, but spinal fusion is a natural way of attaining the stability or maintaining the stability for a long time. The spinal fusion occurs when there is a bony union between any two adjacent parts of the spine. So this we achieve by putting a variety of some bone chips, what we call bone grafts. It's best to get those bone grafts from the patient itself. Typically we harvest the bone chips from the iliac bone, that is the hip bone. We get some chips from the hip bone and put it around certain areas of the spine so that there is a fusion. So yes, it is a major procedure only.
So doctor, what are the symptoms of a failed lumbar fusion?
Sorry for the interruption.
Sorry for the interruption. So doctor, what are the symptoms of a failed lumbar fusion?
Yes. Failed lumbar fusion or failed back surgery we can call it. Failed back, there is an entity itself called a failed back surgery syndrome. Failed back surgery syndrome occurs from a variety of causes. One is the nature of the disease itself. Certain degenerative diseases like lumbar disc disease, even after surgery they can have a persistent pain in the back, can have persistent instability. Sometimes failed back surgery syndrome also occurs with wrong choice of the patient also. Sometimes patient may have a symptom which is unrelated to what the pathology is, what the nature of the disease is. Sometimes when you put an implant, like for example I said screws and other things, it may slip from the original place. All the repeat trauma, all these things can result in what is called a failed back surgery syndrome. So we have to identify the cause for the failed back surgery and then revert causes so that a treatment is given.
Doctor, does laminectomy weaken the spine?
Laminectomy is, as I said, certain areas, one important part of the vertebra or a backbone is the lamina. So removal of the lamina is done in a variety of cases for a variety of conditions. So removal of that part of the bone, that part of the backbone which is called lamina, is called laminectomy. So if the laminectomy involves one segment, for example, in one bone, usually it doesn't cause any great thing. Suppose if it is removed in several segments, say 5 or 6 segments, then there is a possibility of a instability, for which only we do a spinal fixation. And nowadays we undertake what is called micro-invasive surgeries. We can use a variety of techniques like microscopes, endoscopes, so that the part of the lamina which is needed to be removed will be very, very minimized. One such entity is a microlumbar discectomy, doing a disc surgery by using micro-invasive methods like what is called a microlumbar discectomy.
I have one more query from Mr. Kumaresh Balaji. What are the symptoms of brain tumors in infants and small children?
Like in adults, infants and children, they tend to have, they can have brain tumors. But these brain tumors, most of these brain tumors in infants and children, unfortunately, tend to be in the what is called in the cerebellar region, or in the posterior aspect of the back of the brain. So these children, typically they come with, if a child is already started walking, they come with walking difficulty, they can come with a stiff neck, and then they can come with breathing difficulty, swallowing difficulty, and then constant and incessant crying, drowsiness, vomiting, repeated vomiting. All these things can be a symptom of a brain tumor in a child. So a child who is normally been walking becomes very, very unsteady. Along with these symptoms, we should always prompt a person to prompt a pediatrician or other doctor who is treating the child. Should prompt towards diagnosis of a brain tumor. A prompt scan, an MRI scan or a CT scan has to be immediately taken.
So doctor, how are the tumors removed from the brain?
Tumors are typically removed by what is called in a classical sense of the term, we always remove it by what is called a craniotomy. Craniotomy means opening. So if you open the abdomen, it's called laparotomy. If you open the chest, it's called thoracotomy. If you open the skull, it's called a craniotomy. So previously, in olden days, before the advent of microscopes, before the advent of sharp imaging techniques, they tend to open the brain, open the skull with a huge flaps. The huge areas of the skull used to be removed. Nowadays, the size of the flaps that we put, the size of the area of the skull which we open is becoming smaller and smaller with micro-invasive techniques. Sometimes you even use an endoscope. Just put a hole, insert, and for some selective cases, you put an endoscope inside. And another trend is previously, for example, in pituitary tumors, we tend to always go only through the skull doing a craniotomy. Now we go through the nose. That's called an endoscopic pituitary surgery. So there is no need to open the skull at all. In general, the size of the craniotomy has come down. In some few select cases, we have to open the skull a little bit more than what is required.
So doctor, what are the possibilities that the brain tumors can heal without surgery?
There have been very, very rare incidences of brain tumors spontaneously regressing, but these things should be taken as, say for example, as miracles. So, as soon as a brain tumor is diagnosed and the nature of the thing is broadly known, it is wise to initiate the therapy rather than banking on such miracles.
Can immunotherapy be used to treat brain tumors?
Yes, immunotherapy, already I answered in a previous question that immunotherapy is coming up in a big way, but yeah, it does have some promising results so far, but it has not come in a very big way to become a standard therapy of care.
Does brain surgery change your personality?
Personality, as I said, is governed by certain areas of the brain. For example, the frontal lobes. There are certain, in fact, the fact that the frontal lobes are involved in personality has been brought out by a person, a worker who was injured in the frontal lobe during his work, during the course of his work. So the person, his personality absolutely changed after his frontal lobes got injured. That is how they found out, they diagnosed, they came to know that the frontal lobes are involved in personality. So most of the time these frontal lobe tumors or frontal lobe injuries can result in a drastic change in the personality of the patient, which can be easily diagnosed by the persons who are friends or relatives of the patient.
Can brain tumors come back after a surgery?
Recurrence of brain tumors are very high with highly malignant tumors like glioblastoma multiforme. In general, the malignant tumors can recur. Benign tumors, generally the recurrence rate is very, very low. Sometimes it doesn't come at all, and so, even otherwise the recurrent rate, if it is properly fully excised, then the recurrence rate is much low with a benign tumor rather than a malignant tumor. It can regrow.
So can spinal discs be replaced?
Yes, there are disc replacement surgeries. There have been a variety of artificial discs have come for the cervical spine, for the lumbar spine. Artificial disc replacement surgery has been in vogue for several years. Variety of companies manufacture, but there are a lot of debates going on in the spine surgery circles because yes, initially it was very, very promising. Then later studies have proved that it's not that superior to a conventional surgery in the spine.
So doctor, explain us what is spinal reconstruction surgery?
Spinal reconstruction, broadly you can say that any deformity of the spine, what we call deformity is other than the normal anatomy. It can be even congenital. Say for example, a congenital scoliosis, congenital kyphosis, these are the entities which denote that there is a deformity of the spine. It can also be a result of trauma, it can be a result of tumors. All these things can result in spinal deformities. So these things can be reconstructed into normalcy by using again a variety of implants, as I said. So this is the basis of a reconstruction spine surgery.
Is spinal fusion a major surgery?
Yes, I think I answered already. It is a major surgery.
So doctor, what will be your conclusion message for this session?
The main conclusion message that I would tell, yes, brain tumors, many of you have asked about questions on brain tumors and all. Yes, early diagnosis, treatment and all is very important. You have to go to that and get the advice properly, and without hesitation we have to get admitted for surgery. That is one thing. But the most important thing, the message to be carried is regarding the head injuries and spinal injuries. So head injuries, most of these head injuries, the severity of the head injury at least can be reduced by wearing a helmet. Spine injuries, of course, we have to be very careful while driving. These are wearing a seat belt and avoiding rash driving. These are the very important things, because head injuries and spine injuries, both of them, whether the saying that prevention is better than cure is applicable to anything else, it is very much applicable to spine and brain injuries. So that is the take-home message.
So thank you so much, doctor. For appointments with Dr. S. Sundararajan, Senior Consultant Neurosurgeon, Apollo Specialty Hospital, Madurai, please contact 0452 434 1092, 0452 258 0892.
Thank you very much.